So you need to understand the live vaccines, and you know that all live vaccines are contraindicated during pregnancy. So when one is pregnant and then the person is being prescribed with a live vaccine, you need to make a follow-up on that and then um, rectify that. Other than that, if the live vaccine is given, it's either going to lead to miscarriage or it can lead to some form of congenital abnormalities. So live vaccines are not allowed to be given during pregnancy. And one of them is rubella. And so rubella is a live vaccine. So the MMR, mumps, measles, rubella, these are the live vaccines, and all these three are not to be given during pregnancy. We only give them after the woman has delivered. So it's during the postpartum stage that you give your live vaccines. So when it comes to rubella, you have to do the rubella titer. The titer tells you the state of the woman as to whether the woman is immunized or not immunized. Under normal circumstance, the woman would need to be immunized, okay? But if during pregnancy you do the titer and you realize that the woman is not immunized against what we call rubella, and we have the value. So in your questions, you'll be seeing the value. So if you see in your questions that after a rubella titer, the person's the outcome is less than 1:8, it means that the person is not immunized. And the person at that point can be susceptible to what we call rubella. However, you can't continue to immunize the person or give the vaccine while the person is pregnant. You rather have to wait after the delivery. That is when you give the vaccine. And when you give the vaccine, you have to also make sure that the woman stays for at least 3 months before they get pregnant. So when you receive a rubella vaccine, you don't have to give, or you don't have to get pregnant within 3 months. If you still want to continue, enjoying yourself, you have to protect yourself. And so that is what you need to understand. Effective birth control measures would have to be put in place for at least 1 to 3 months after delivery in the post-op stage and the woman has been given the rubella vaccine. They would also have to understand that this vaccine should not be given together with RhoGAM, because the RhoGAM can make the vaccine to become inactive. So when you are to give both RhoGAM and then what we call rubella together, you have to space them. And we know that RhoGAM has a certain number of days or hours you need to give it. And so if a woman delivers and then within the 72 hours that you need to give RhoGAM, if there is a need for you to give RhoGAM, you have to give the RhoGAM first. Wait for after the RhoGAM has been given for about 1 or 2 days before you give your vaccine, because the vaccine can wait, but then the RhoGAM cannot wait. For the RhoGAM, you can't postpone it after 3 days or 72 hours, okay, like we discussed last week. So you have to make sure that you are giving your gum first and then later you give your vaccine. We've talked about you can give it. So we also have to understand that you have to inquire about as to whether the person is having sensitivity to eggs. And so people who are allergic to egg, they would also might not be candidates for rubella vaccine. So you have to also inquire about their sensitivity to eggs before you can give the vaccine. So the last thing is that it is live attenuated and then it can cross the placenta barrier, causing some form of congenital abnormalities, can even cause miscarriage and all that. And so you have to make sure that you are not giving your rubella during pregnancy. So that is on rubella vaccine, and then the titer, and then what you need to know about it as we are preparing for English. The next thing we'll talk about is glucose challenge test and how to diagnose what we call gestational diabetes. Gestational diabetes is very important. We need to understand it. That in the US, these are standard tests that are done to rule out any form of if to find out as to whether the woman is having gestational diabetes, which comes during pregnancy. And we know that there are a lot of factors that can influence the release of what we call insulin to help with glucose metabolism. Pregnancy is one because during pregnancy, there are quite a number of hormones that are released during pregnancy. And these hormones affect what we call some of the hormones, or the hormones can affect insulin release. So when that happens, it also affects glucose metabolism. So because of that, you need to screen all pregnant women to see as to whether they are at risk of gestational DM. And if the person is having gestational DM, it needs to be managed, okay? Because if you don't manage it, one, the child or the fetus can become very big. So there's macrosomia there. Okay, macrosomia becomes something that you need to consider if the woman is having gestational diabetes. Then when the child is also born, because whilst the child while the child was still in the uterus, the child was getting a lot of glucose from the mother. So the body was also producing what we call insulin to rectify that upon delivery, because the child will not be getting that amount of glucose from the mother, and the body will still, or the pancreas will still be producing the insulin. The child or the infant, the newborn, will be at risk of what we call hypoglycemia. So these are the reasons why you need to screen the mother to see as to whether they have gestational diabetes. And we have the weeks that you can screen someone for. You can screen someone for gestational diabetes. You cannot just say that someone is in, let's say, 10th week of gestation, so you're going to screen the person for gestational diabetes. No, it is not done that way. And so gestational diabetes is done. You can screen someone for gestational diabetes and confirm it between 24 weeks and then 28 weeks. That is a week duration at which gestational diabetes can be diagnosed and confirmed. So now let's go into the details. We'll look at the general fasting, the general glycated hemoglobin. Then we'll also look at how to go about 1 hour glucose challenge test, and then 3 hours glucose challenge test. The two of them, we have ways to go about it, and then you do it. So the first point I have here is that when it comes to screening, the initial prenatal visit before the client, the first visit or the initial visit, you have to screen the person, do your normal fasting or random or glycated. Now, when you do any of these three, hello, kindly mute up. Charity, kindly mute up for us. Hello. All right. Okay. So when you do your when you do in the initial stages, let's say the first visit of first two visits before 24 weeks of gestation, you do either fasting, you do either glycated, or you do random. When you do random and you realize that the figure is high or the value you had is high, you have to wait and then do your glucose challenge test which will help you to confirm that indeed the person is having gestational diabetes at 24 weeks and then 28 weeks. That is the week duration by which you can do glucose challenge test to confirm that there is gestational diabetes. So in the initial stages, if you do the fasting and the fasting is greater than 126 milligram per deciliter or 7.0 millimole per liter, you know that the glucose level is high. So when you notice that, you have to prompt the healthcare provider so that between 24 weeks and then 28 weeks, the glucose challenge test will be done. Or if glycated is done, we know that glycated helps you to monitor how well one's glucose level is being controlled within a space of 3 months. That is where we call it hemolysis, or the time duration for normal red blood cells to last for. Okay. Normal red blood cells last between 90 to 120 days, about 3 months. So we have glucose that are attached to the red blood cells. And this glucose, since they are attached to the red blood cells, will stay in the system until the red blood cells are broken down or they are destroyed, which will take about 3 months. And so the glycated will help you to know how well one is controlling their glucose level. So when you do glycated too, the values are, or it's in percentages. Okay, let me put it that way. It is in percentages. For normal glycated, or for a normal person, your glycated should be less than, I think, 5.7. Yeah, that's what most of the books use. 5.7, less than 5.7 is the ideal for any person, any normal person without any issue with glucose. Now, if you get between 5.7 and then 6.5, that is prediabetes. Between 5.7 and then 6.5 is prediabetes. When you are getting above 6.5, it means that you have DM, or that should ring a bell that your glucose regulation or your glucose control is very bad. So if they do glycated in the initial prenatal visit and notice that glycated is more than 6.5, that is HbA1c is more than 6.5, then the healthcare provider will notice that. And then at 24, and then between 24 and then 28 weeks, I talked about fasting glucose. I also talked about glycated, which is HbA1c. I was on a random, and we know that random, for random, a normal person, your random should be less than 11.0 or 11.1. That is what your random should be less. If the random is more than 11.1, which is 200 milligram per deciliter, that is bad. Okay, so in pregnancy, in the initial stages, if this is done and then it is noticed that someone's random is more than that, the healthcare provider would have to notice that. And then between that space, 24 to 28 weeks, the healthcare provider will do glucose challenge test for the person to confirm that indeed the person is having gestational diabetes. And then you don't need to do all this theory. At least one will be done. If it is fasting, we only do fasting. If it is glycated, we do it glycated. If it is random will be done. And then the value will determine what will be done between the 24 and 28. Okay. Now, the next one is talking about, and so we're going to go into the glucose challenge test, which is a two-step approach used in screening for gestational diabetes. So if you have, like I said, any of the three, if you are crossing the normal range, first of all, we do the first 1 hour glucose challenge test. The 1 hour glucose challenge test like the name goes, 1 hour. So it means that you have to do something and wait for 1 hour before we screen you. So what you will be doing is that between the 24 and 28, that is when you do this. Between 24 and 28 weeks of gestation, that is when the 1 hour and then the 3 hours are done, or the 3-hour glucose challenge test is done. So the 1 hour, you take 50 grams of glucose load. When you take the 50 grams of the glucose load, you have to wait for 1 hour. Then when you wait for 1 hour, then a repeated test will be done, or will now screen you. The healthcare provider will now do what we call the check your glucose level. When your glucose level is checked and the value is greater than 140 milligram per deciliter, that is 7.8 millimole per liter, the healthcare provider will not go ahead and say that you are having gestational diabetes. You have crossed the boundary. He will still wait and then do what we call the 3-hour glucose challenge test. Now, when it comes to the 1-hour glucose challenge test, you can do it at any time, regardless of, whether the client has fasted or not. It can be done at any time of the day. You can do the 1-hour glucose challenge test. And so if the 1-hour glucose challenge test is done and it's less than 140 or 7.8, the healthcare provider will not do the 3 hours, the 3-hour glucose challenge test. So the 3-hour glucose challenge test is only done if 1-hour glucose challenge test is more than 140. That is the confirmatory test. So let's go into the 3 hours. So when it comes to the 3-hour glucose challenge test, the healthcare provider, the patient would have to fast for at least 8 hours. Okay, you fast for at least 8 hours. So mostly, preferably, it is done early in the morning, when you had probably slept, woke up early in the morning. Then the test will be done. So what goes on is that for the 3 hours, like I said, you fast for at least 8 hours. When you fast for at least 8 hours, then the same glucose amount will be given to you. Then you wait for, after taking the glucose, you wait for 3 hours, and then the test will be conducted. And so when the test is conducted and we get above 130 to 140, that is 7.2 to 7.8, that is when you are considered at having gestational diabetes. And so these are the processes or the steps that one has to go through before you are said to have what we call gestational diabetes. If you have a question on glucose challenge test and how to screen for gestational diabetes, you can bring it up. Where you don't understand, you kindly let me.
Yeah, Sinamingo, please kindly touch on the last aspect.
Okay, so the last aspect is that first, after doing the initial one, you do 1 hour and 3 hours. 1 hour is regardless of time. You can do it any time of the day. The only thing you do is that the client takes the glucose, 50 grams of the glucose, and then they wait for 1 hour. After 1 hour, you check their glucose level. If the glucose level is more than 140 milligram, the reason I'm using the 140 is because the US, they use the milligram per deciliter, but whatever it is, they will give you the millimole per liter value. So if it is above 140, the healthcare provider will go ahead and do the 3-hour glucose challenge test. Now, if it is less than 140, if the 1 hour is less than 140, he or she will not do the 3-hour glucose challenge test. So the 3-hour glucose challenge test is where the client would have to fast for at least 8 hours. So after fasting for 8 hours, you take the glucose, the same amount, 50 grams, you wait for 3 hours. Then the healthcare provider will now test your glucose level. If the glucose level is between or is more than 130 to 140, then that individual is said to have what we call, gestational diabetes.
Oh, okay, thank you.
All right. Hello, feel free to come up with your issues and it's normal. Feel free to come up with your issues. If you have anything, if you don't understand anything, just draw my attention to it and then we'll go through together again. All right. So let's continue from there. Let's go to amniocentesis. Of course, amniocentesis, you just need to know when amniocentesis can be done. And when you do amniocentesis, what are some of the things that you need to monitor the client for?
Infection.
You have to make sure that, of course, we are, hello, is someone talking to me? So what you need to know is that with regards to amniocentesis, you are only aspirating the amniotic fluid to screen the child or the fetus for any form of developmental issues, or let's say for any form of gestational genetic disorders. Let me put it out, for any form of genetic disorders. It is only when you aspirate the amniotic fluid and then the test will be conducted. So that is the purpose of amniocentesis, and it comes with a whole lot of complications. So it is not commonly done unless there's the need for it to be done. The last time someone was asking, when we're discussing on the resource thing, someone was asking, why can't you do the testing whilst the fetus is still in the utero to find out the status of the fetus? The reason is that you can do that through amniocentesis, but the risk that comes along with it, most healthcare providers don't like to do. So they would wait for the delivery. After delivery, that is when the sample will be taken from the fetus and then the test will be conducted. And so amniocentesis comes with a lot of complications. We'll go through it very soon. So before you do that, before the healthcare provider do amniocentesis, you need to make sure that an ultrasound is done. When the ultrasound is done, it will help you to determine, where the needle will be inserted, so that the healthcare provider will now be guided when it comes to inserting the needle. The test is mostly performed between 15 to 20 weeks of gestation, because that is when you have adequate amount of the amniotic fluid, and then that is when most of the cells of the fetus also are also viable. So you can easily pick up the cells, and then whatever you want to screen the fetus for, you can do that. So as a nurse, of course, this comes with it's an invasive. The healthcare provider would have to insert a needle, and so a consent form would need to be obtained. And so all invasive procedures, you need to ensure that you are obtaining a consent. You have to also make sure that the procedure, like I said, if the procedure is performed at less than 20 weeks of gestation, the client should have a full bladder, okay, to prevent any form of puncturing. And if it is after 20 weeks of gestation that the procedure will be performed, you make sure that the bladder is also empty. So if it is before 20, bladder has to be full. And if it is less than 20 weeks, you have to also make sure that the bladder is empty. So that is on the bladder in terms of the procedure. Ultrasound, like I said, you need to take ultrasound so you can locate the placenta and know where you can do your puncture. you have to take baseline vitals. Very, very, very important. When it comes to amniocentesis, one of the key things that you need to note is assessing your vitals, baseline vitals before the procedure. The reason is that because we are introducing a needle, infection is the greatest risk here, okay? Because you can introduce infection. So you take your baseline vitals, and when you notice that after the procedure, there is any form of, alteration in the patient's vitals after the procedure, you have to notify the healthcare provider. If it is temperature, you know that it is infection. If it is either BP or your pulse or your respiratory rate, it could be that the patient is probably bleeding after the procedure. That is why there's that form of alteration in the vitals. Then you also have to look at the heart rate. And so fetal heart rate. If the fetal heart rate after the procedure, there's any form of issue with the fetal heart rate, you need to inform the healthcare provider. So you do this monitoring every 15 minutes. Okay. You do this monitoring every 15 minutes. You have to position the patient supine during the procedure. Then after the procedure, you position the patient on the left side afterwards. So that is on patient position when it comes to amniocentesis. The complications that can arise after this procedure, I think I did mention of infection. Then I've talked about bleeding. So hemorrhage is one of the risk factors because you are introducing a needle. You can cause, associated organs, you can puncture them, you can cause bleeding. So hemorrhage is there. We also have miscarriage. That is why it is not commonly performed unless there's the need for it to be done. Then fetal injury can also occur, infection. Then if the woman is, let's say, rhesus negative, and then you do this procedure, and there's any form of maternal and fetal blood missing, you can cause iso immunization, or you can cause fetalis blastosis, right? So you need to make sure that's why it's not really done like that. Then you can also cause abruptio placenta, where you have premature, separation of the um placenta. Okay. And so you have to make sure that you don't do this on a regular basis. Then you can also cause a rupture of the membrane as well. My take-home message here when it comes to this procedure is that after amniocentesis, one of the key things you do is that you monitor the patient for infection. Infection is one of the commonest things that can happen after amniocentesis. So if the patient is complaining of chills, temperature is greater than 100.4, that is 38 degrees Celsius, you need to ask the client to come. Bleeding, any form of clot or tissue passage, or there is any form of leakage of fluid at where the needle was. If there is any of these things reported by the clients, okay, or in your questions, you are seeing these things after amniocentesis, you have to make sure that the healthcare provider is notified as the first thing you need to do on that. That is on amniocentesis. If you have a question, you can bring it on board as well. All right, so let's go into stress test and then non-stress test. So pay attention here. This thing I'm coming to do is just like what I did during the glucose challenge test, okay? The outcome of non-stress test will tell you as to whether you should go ahead and do contraction stress test, okay? Now, non-stress test, like the name goes, non-stress. So during this period, you will not stress the woman. You are not going to ask the woman to do anything that will cause some form of contraction. So you have to make sure that, oh, so this is done under, normal situations without any form of oxytocin or the woman doing anything. This tells you how well the fetus is receiving oxygen. Non-stress tests help you to know how the fetus is getting adequate oxygenation and how well the placenta is also functioning in terms of its delivery of oxygen to the fetus. So the outcome also will tell you if the woman or the fetus can go through the normal spontaneous vaginal delivery. Okay. If the outcome comes out to be good, we looked at what a good outcome is and we looked at what a bad outcome is. When the outcome comes out to be good, it means that the placenta is receiving or the placenta is functioning well, and the fetus is also and the fetus is also Please, if you have a question, sometimes I'm not able to go through the chat, okay? If you have a question, kindly draw my attention. Because sometimes I only go there once a while, but then I might have passed where you had a question. So if you have a question, kindly unmute and draw my attention to it, okay? If you use the chat box, I might not be able to go to the chat box and then look to the question. So just do that for me. All right. I just went to the chat box. I saw questions on some of the things I've already talked about. I'm trying to mute this person. Okay, let me go on. All right. So I was talking about the outcome of non-stress test and what it stands for. So non-stress test will help you to know as to whether the fetus can go through spontaneous vaginal delivery, the stress that it comes with it, or a cesarean section will need to be done for the fetus. So this test evaluates the fetal heart rate response to fetal movement. So it will help you to know how the fetus acts or how the fetal heart rate behaves when there is fetal movement. Does the fetal heart rate stays the same during fetal movement? So it's just like you running or you doing some form of exercise. What do we see? When you run or you walk or you do exercise, you see that your heart rate goes up. And so the same thing, it is expected that during fetal movement, we should see some form of increase or some form of acceleration in the fetal heart rate. If during fetal movement, the fetal heart rate stays the same or drops, then that means that there is an issue with the fetus. It is either the fetus is not getting adequate oxygenation. That is why this problem is occurring. So, like I said, during fetal movement, under normal circumstance, the heart rate should increase or the heart rate should also go up. That the fetal heart rate should go up. So let's go into it details. The first one so the instructions or the procedure is that they are going to connect monitors, okay, ultrasound transducer, and then toco dynamometer. These are monitors that are applied on the woman during the procedure. So the monitors will help you to monitor how the fetal heart rate was behaving during fetal movement. And this procedure is done within 20 minutes. So during the 20 minutes, you will give the woman something connected to the monitor to press whenever they feel fetal movement. So you only also do this when the mother tells you at the time that the fetal movement is really active, that is when you do this procedure. So what you do is that you give the woman the something, it's like they press it, okay, whenever they feel the movement of the fetus, then it will pick on the machine. It will record when the fetus was moving. Then afterwards, you go and look at the fetal heart rate on the monitor when the fetus was moving. During the procedure, you also have to monitor the blood pressure, the fetal heart rate. You position the woman on the left side. I've always been saying that when it comes to positioning in maternity, unless you are doing other things, if not, left lateral will be the most preferred position to prevent what we call vertebral compression on the aorta, which will lead to a drop in the blood pressure, leading to syncope and all that. So you have to position the woman on the left lateral. So the client may be asked to press a button. So that is what I was talking about. They will press a button on the monitor whenever they feel fetal movement. The monitor will record a mark at each point of the fetal movement, which will be used as a reference point in terms of the heart rate, in terms of the
Esa.
heart rate, okay, in terms of the fetal heart rate. All right. So you ask the woman to press the button on the monitor whenever they feel the fetal movement. Then after the procedure, after the 20 minutes, we're going to look at how the fetal heart rate was behaving during fetal movement. Now let's go into the interpretation of the result. So the result is that you get a reactive non-stress test, which is normal, and it is also negative. Normal negative means that the fetus is doing well, and we call it a reactive non-stress test. So a reactive non-stress test indicates a healthy fetus, and what should tell you that this is reactive. So I said that during fetal movement, under normal circumstance, you expect to see a rise or an increase in the fetal heart rate. If there is an increase in the fetal heart rate during fetal movement, then indeed it tells you that the fetus is doing well. The fetus is getting adequate oxygenation. So how should all the movement, the increase also be? The increase shouldn't be something less than 15 beats. So it says that the results require 2 or more fetal heart rate acceleration. Acceleration is increase, so you can replace acceleration by increase. Fetal heart rate acceleration of at least 15 beats per minute, lasting at least 15 seconds from the beginning of acceleration to the end. So that means that at any point that the mother feels that the fetus is moving, after the moving off, during the fetal movement, the fetal heart rate should move or should increase by at least 15 beats per minute. And when it increased by the 15 beats per minute, at least it should stay there for at least 15 seconds. Now let's look at what the baseline. So example, let's say that the fetal heart rate, the baseline fetal heart rate is, let's say 120 for a certain woman who is going in for a non-stress test. For you to note that the non-stress test is reactive or it is normal, during fetal movement, the fetal heart rate should increase from 120 to at least, so you add at least 15 to it. So 120 plus 15, you are going to get 135 to at least 135. Then when it gets to the 135, it should stay there for at least 15 seconds. before it drops back to the baseline. I hope I'm making sense. That during fetal heart rate, during fetal movement, the fetal heart rate, if it is 120, it should increase by at least 15 beats. And so the 15 beats, if you add it to 120, you're going to get 135. And so you get 135 during fetal movement. And it should stay at the 135 for at least 15 beats, 15 seconds before it drops back to the baseline. When this happens, it means that the fetus is doing well. It's getting enough oxygenation through the placenta or through the cord. And so everything is fine. So this happens during, the 20 minutes duration. You have to do this monitoring for at least 20 minutes. Then you come to the non-stressed, the non-reactive. So non-reactive is what? Is abnormal. Okay. Non-reactive is abnormal. It means that the fetus is not probably getting adequate oxygenation and might not be able to withstand the stress of spontaneous vaginal delivery. So that means that during fetal movement, you will not see that kind of increase I was talking about. It is either there is going to be an increase, but it wouldn't be up to 15 beats per minute, or it will stay the same during fetal movement, or it might even drop, whatever it is. If it is not up to 15 beats per minute and it is not able to sustain for at least 15 seconds, that is a bad outcome. So a non-reactive non-stress test, that which is abnormal, is that no acceleration or acceleration of less than 15 beats per minute lasting less than 15 seconds. And when you notice that on your monitor, at least you should continue the monitoring for 40 minutes. Okay. So for a reactive or normal, you monitor for 20 minutes. When you go to check and you notice that the fetal heart rate is not moving above 15 beats per minute, or not moving at least 15 beats per minute, and you continue the monitoring for 40 minutes, for 40 minutes. And then after 40 minutes, you pause and you know that the outcome is, non-reactive, which is abnormal. So when it is abnormal, the healthcare provider will now go ahead to do a contraction stress test. So it is the contraction stress test that will best tell you that indeed the fetus, blood supply to the fetus is compromised, or the fetus is not getting adequate oxygenation and is not doing well. So, but if the result is reactive and it is normal, no need to go ahead to do the contraction stress test. So contraction stress test outcome is dependent on non-stress test outcome. So most of the questions in the Q bank, you will see that a healthcare provider requested a non-stress test for a client. After the procedure, the result was reactive, and they will ask you, what are your interventions? They will bring, like, allow the client to go in for contraction stress, to continue to monitor the client, and then other interventions will also, or other options will come. If it is reactive non-stress test, it means that the fetus is doing well, so you continue to monitor the client. No need for any further interventions. However, if it is non-reactive, if in the question it stated that the outcome was non-reactive non-stress test, and you have that, continue to monitor, do a contraction stress test, and then any other options or interventions, you have to note that because it is non-reactive, the client has to do a contraction stress test. So after non-stress test, you do a contraction stress test. Before I go through the contraction stress test, if you have an issue or you have a question, you can bring it up. Okay, that is okay. Sorry. So let's go through contraction stress test. So like I said, the contraction stress test. So here the name goes stress test. So it means that during this procedure, the woman is going to be kind of stimulated to go under a certain form of stress. And this procedure is also done at when the woman is in term gestation. Okay, so you only do this after 37 weeks going, because here you are going to stimulate contractions. And if you stimulate contractions and the woman is not at term gestation, you are probably going to cause preterm delivery or preterm. So contraction stress test is done when the woman is at least 37 weeks going. And you know that at 37 weeks, if delivery occurs, it is 10. And so there will not be much issue to worry about. So you can't do this procedure, or you can't do contraction stress test if the woman's gestation is less than 37. So this also tells you how the fetus is doing in terms of oxygen supply and how the placenta is also functioning. It it determines the fetal ability to tolerate labor and determines the fetal well-being. So this is a follow-up test to confirm if the fetus can really withstand labor stress, or they will need cesarean section to be done. So the fetus is exposed to stress of contraction. So that's why I was saying that you're going to give oxytocin, a diluted form of oxytocin, or nipple stimulation. Nipple stimulation too also causes what we call contraction or stimulate contractions. So you either give what we call the oxytocin to stimulate the contraction. So this test is performed if it is believed that the fetus needs to be delivered and the ability to tolerate the labor is unclear due to a failed non-stress test. So a failed non-stress test is the same as a non-reactive non-stress test. The interventions are the same, or this quite the same. The patient will be monitored on a monitor, or a monitors will be applied. Then you give the oxytocin, a diluted form of oxytocin, to stimulate contractions, or nipple stimulation. So these two things are done. Either they give the diluted form of the oxytocin to stimulate the contractions, or you have to do what we call the nipple stimulation, for which will lead to contractions. Okay. During that, you have to monitor the woman, you have to monitor the fetal heart rate, because you are giving oxytocin. Now let's go into details of the outcome of the test. When you do the test, we are looking for a negative contraction stress test. And so a negative contraction stress test is where you have, it is good. It means that the fetus is fine, can go through normal spontaneous vaginal delivery without any issue, or can tolerate the stress of labor. And so during the contractions, when the oxytocin was given, what you are looking for is that during that period, was there any form of deceleration, late deceleration? Late deceleration is a drop in the fetal heart rate. Okay, so the name is decel. Decel is dropping. So when you look out for, is there any form of a drop in the fetal heart rate? These are the things you are looking out for. And so for a negative contraction stress test, which is normal, a negative result is represented by no late decel. We'll go through, the various fetal heart rate monitoring, and then we'll look at, how to also read a fetal heart rate on a monitor. Okay, like how you read fetal, EKGs. We'll also look at how to also read this one as well. And so you understand how late decel looks like. And so during the contraction, after giving the oxytocin, if you notice that there is no late decel is when you have the fetal heart rate dropping to about less than the baseline. Okay, so it says that in late decel, the fetal heart rate will drop below the baseline, but at least it will stay above 100. Okay, however, it will drop below the baseline, but we know that normal fetal heart rate is between 110 to 160. And so when you give the oxytocin or you stimulate the contraction and you notice that there is no form of drop in the fetal heart rate, it means that the fetus is doing well and can go through the normal spontaneous vaginal delivery, and that represents a normal contraction stress test or a negative contraction stress test. However, if after the procedure you notice that on the monitor there is a drop in the fetal heart rate, or there is a late decel, there is a late deceleration, then that should tell you that the fetal heart rate or the fetus cannot withstand the stress of labor. And so the healthcare provider at that point will go in, will send the woman in for cesarean section to be done. So that is positive. Positive contraction stress test is abnormal. And a positive result is represented by late deceleration of the fetal heart rate with 50% or more of the contraction in the absence of hyperstimulation of the uterus. So all that we need to understand is that for a positive contraction stress test, which is negative, which is abnormal, you are looking for a drop in the fetal heart rate. Is there a drop in the fetal heart rate when you give your oxytocin to stimulate contractions? If that is there, then that is abnormal, and the healthcare provider would need to be notified. And then if the woman had planned to go in for normal spontaneous vaginal delivery, the woman will not be allowed to do that. They would have to go in for cesarean section to take off the baby. And so that is on the various testings that are done during the antepartum, sorry, antepartum stage or the prenatal stage before the delivery. I think
All
I've
right.
talked for a lot.
Question. You can please go back to the previous slide before the results. Yes.
Okay.
So, the interventions, maybe I did not hear you talking about it.
Okay.
So I would like if you can go through that one. Thank you.
Oh, okay. Okay. So the interventions you do, I think I did mention some of them. So the monitors, external monitors will be applied, just like what happens in non-stress test. You do and the procedure is done between a space of, or a time duration of 20 to 30 minutes. That is when, you do this procedure, or you monitor the fetal heart rate. So you do it just like we said that in non-stress test, you do it in a space of about 20 minutes. If it is normal, if it is abnormal, you continue the monitoring for 40 minutes. Here, you do the procedure for about 20 to 30 minutes during the monitoring. And then like I said you give oxytocin. I did mention about that. So that is a second point. Or either you are giving the oxytocin to stimulate the contractions, or the woman, you do nipple stimulation. So nipple stimulation also can cause contractions. Okay. So the healthcare provider will choose one of them, either the oxytocin giving or the nipple stimulation. Then you have to also monitor the blood pressure of the woman whilst oxytocin is ongoing. And then all other vitals, you need to monitor them as well. Hello, the one who wanted me to go back again. Are you okay now?
Yeah, I'm good. I'm good.
You know, okay.
Thanks.
All right, that's fine. Yes, is there any other question, any other input clarification here? All right. Okay, let's go through If you don't have anything, I think I have some questions for you. Kindly come up with your answers, okay? I'll not be reading from the chat box, okay? So kindly come up with, just raise up your hands. The questions are not quite difficult, they're just straightforward. So you come up with your responses or your answers to the questions, and we'll go through a few of them and we'll continue with what we have to do for today. The next thing we do after this. The nurse is providing instruction to a pregnant client who is scheduled for amniocentesis. What instructions would the nurse provide? Strict bed is required after the procedure. Hospitalization is necessary for 24 hours after the procedure. And informed consent needs to be signed before the procedure. For a fever is expected after the procedure because of the trauma to the abdomen. All right.
Please, I think
Yeah.
to be an informed consent is needed to be signed before the procedure.
Okay.
I also
So,
go for option 3.
okay.
I also go for 3.
All right. I think it's just straightforward. Okay. Like I talked about first, it's this straightforward. I mean, invasive. So consent form would need to be obtained before the procedure. It says that a non-stress test is performed on a client who is pregnant, and the result of the test indicates non-reactive findings. The primary healthcare provider prescribes a contraction stress test, and the results are documented as negative. How would the nurse document these findings? There are some questions here. Let me see if I can post this one. Right.
I'll go for option 2.
Option 2, an abnormal test result. Okay. Is there anyone with? I think people are also going for.
I'll go for option 1.
Okay, go for option 1. So someone's going for 1. It's the normal. Someone says it's normal test result. Okay. All right. I want the. So I'm dropping some questions on the page. It's on, I think, glucose challenge test. I don't have them on my slides here. So whilst we are going through this, you can read from there as well, and then you drop your answers there. I'll drop the rationales as well on it. Okay. All right. I should have included this here. Oh, no, not this. Okay. A rubella titer result of a 1-day postpartum client is less than 1:8. And then a rubella virus vaccine is prescribed to be administered before discharge. The nurse provides which information to the client about the vaccine, etc. Breastfeeding needs to be stopped for 3 months. Pregnancy needs to be avoided for 1 to 3 months. The vaccine is administered by the subcut routes. exposure to immunosuppressed individuals needs to be avoided. Hypersensitivity reaction can occur if the client has an allergy to eggs. The seed point is that the area of injection needs to be covered with a sterile gauze for at least 1 week. Okay.
Sinamengo 2, 3, 4, 5.
2, 3, 4, 5. All right. Small going for 1, 2, 3, 4, 5. So 2, 3, 4, 5. 1 is not passed. Sorry. The person did not add the 5. I added 1 to it. Okay. All right. So let's see this. Which of the following are required?
Please, can you go back to someone for me? Gestational. I'm taking a pic.
You pay for the
Yes,
you pay
yes.
for taking a shot of it too.
All right, thank you, thank you.
All right. All right. So which of the following are required for a non-stress test to be considered reactive? It's SATA. 2 increase in the fetal heart rate of 15 beats per minute. 2 decreases in the fetal heart rate of 15 beats per minute. 2 increases in the fetal heart rate for 15 seconds. 2 decreases in the fetal heart rate for 15 seconds. A moderate viability, absent viability.
AC.
Tell me why you're going for the ANC.
Yes.
Okay, so you stated earlier that with the reactive non-stress tests, usually it is negative and normal. So the fetal heart rate, there's supposed to be a fetal heart rate acceleration that is lasting for 15 minutes.
15 seconds.
Sorry, 15 seconds. So
Okay.
meaning with an increment of 15 minutes. So assuming it's 120, there's supposed to be an increase of, let's say, 135, 135.
Okay.
Yes. So that is what I'm going in for. Two increasing in the fetal heart rate of 15 beats per minute, and that of 2 increases in the fetal heart rate for 15 seconds.
Oh, okay.
Yeah.
Thank you. So A and C, right? Just like he said. Okay, I did this last week. Yes. The nurse is assessing a client during the first routine prenatal examination according to the last menstrual period. The estimated gestational age is 12 weeks. The nurse would expect to palpate the uterus fundus 1 just above the symphysis pubis at the level of the umbilicus, 12 centimeters above the umbilicus, just below the zyphnoid process. Okay. Yeah. People prefer to answer in the chat box. Okay. That's okay. But two is that this question is on glucose challenge test. The nurse is teaching a client at 24 weeks gestation who is scheduled for a 1-hour glucose challenge test. Which of the following statements by the client would require follow-up? I will need to fast for 12 hours before the test. The test involves drinking a 50-gram glucose solution. I should not eat anything for 1 hour after drinking the glucose solution. A 3-hour glucose tolerance test is indicated if the result is elevated. So which of these statements from the client requires you to intervene or make a follow-up on it?
1.
1.
One there, okay. That's my last question now. The nurse is caring for a client at 12 weeks gestation who has a rubella titer status of non-immunized. Which of the following actions should the nurse anticipate implementing? Administer measles, mumps, rubella vaccine now. Administering MMR vaccine immediately postpartum. Administering MMR vaccine in the 3rd trimester. Informing the clients an MMR vaccine is not indicated.
2.
All right. Do this in the postpartum, as we also talked about. It's fine. So you see the three vaccines all combined here, MMR. Okay. Okay, we're not doing this today.
Can I please go back to the last question?
Last question.
Yeah, the rubella one.
This one.
Yeah.
Okay.
Okay.
This one it says that and this is caring for, this is on a resource factor. This is caring for a client at 27 weeks gestation after a motor vehicle collision with side airbag development. The client's blood type is O negative. Which laboratory tests should the nurse anticipate?
2. Indirect Combs test.
Indirect home testing. Okay. Yeah. So I think I mentioned of the comb tests, direct and indirect. Direct on the mother. Indirect, you have to. Okay, so let's go on. So we are continuing. I'm dropping the questions I was talking about. There are 2 of them. It's on the page now. You can produce your answers. Later, I'll drop the answers to it, and then they are on glucose challenge test. I think there are 2 of them. And then later, I'll drop the questions, the answers to them as well on it. Okay, so let's make progress. And now next thing we're looking at is some risk condition related or conditions that comes about during pregnancy. And our first thing we talk about is DIC. DIC happens to be one of the conditions that is if you are preparing for English. you should understand it very well. It's quite common in pregnancy. However, down here we've been associating it much more with pregnancy. And so you might think like the number one cause of DIC is pregnancy. However, the commonest cause of DIC is infection or sepsis. Okay, because infection and sepsis are quite different. Sepsis is severe form of infection. Okay, you can't just call just a normal infection as sepsis. All right. So we looked at DIC and we looked at the predisposing management and all that. And so when it comes to DIC and the management, you have to tune your management towards the underlying cause. Okay. You have to look at what is the underlying cause of the problem, and then you direct your management towards that. If it is about sepsis that is causing the problem, you have to treat the infection. If the infection is treated, the problem will be resolved. And so when it comes to pregnancy proper, there are quite a number of factors that can lead a woman into having a disseminated intravascular coagulation. And so this is, the name goes coagulation, so it has to do with blood clotting or cascades of events that leads to clotting. Under normal circumstance, when you get an infection, or when you get, let's say, an injury, you need clotting factors moving in to where the injury occurred to help control the bleeding. In people who have DIC, what happens is that there is rapid clotting that goes on in the system. And when that rapid clotting happens, it rather leads to depletion of clotting factors, because it's just like you eating and then you eating faster. You finish all the food. But if you had taken your time to eat the food slowly, you would have been able to finish it well than just rushing through. And so the rush that it comes with it for clotting factors to move to a site to probably help prevent injuries, prevent bleeding, or rather leads to what we call the depletion. At the end of the day, it will lead to depletion in the clotting factors, and the patients will rather continue to bleed more. So if you want to understand DIC, you can bring it at that stage, or you can break it down to that extent and you get understanding. So here is where you have clotting cascades getting activated. It could be during infection, it could be during injury when the woman is probably
Even the rubber pile.
when the woman is probably bleeding, where you need these clotting factors to be moved in there. When the clotting factors move in, because of the rate at which they are moving towards the site, it can lead to a depletion of generalized, or it can lead to a depletion in the clotting factors in the system. And this person will tend to have generalized bleeding, or they can bleed more, not from a specific site. So they will present with issues of bleeding. So there's rapid and extensive formation of clots that occur in DIC. Like I said, a lot of clotting factors will move. And so when it happens like that, you have a lot of clots formation, which causes the platelets and then clotting factors to be depleted. We know platelets will help with to stop bleeding, platelet aggregation during injury to help with bleeding. And then we have other clotting factors that are produced, in the liver and another part of the system to help control bleeding. And so these factors will all suppress or will reduce. And when it reduces, The result is that there is bleeding and potential vascular occlusion of organs from the clots that has formed. So this is the general overview of what we call the IC. The predisposing factors, specifically in pregnancy, is that when there is abruptio, when you have the placenta separating prematurely, then you could also have amniotic fluid embolism. So this will mostly happens during what we call amniocentesis, when probably a sample of the amniotic fluid is being taken. Then you could also have gestational hypertension. Okay, so we'll go through gestational hypertension very soon. Then we also have HELP syndrome. So the HELP syndrome is where you have hemolysis. And so that is a syndrome by itself. Hemolysis, where you have the red blood cells breaking down. Then you also have low platelet count. And so low platelet count, hemolysis, elevated liver enzyme. And so elevated liver enzymes could also lead to DIC because the liver also has a role to play when it comes to production of what we call clotting factors. Then you have intrauterine fetal death. So when you have that also occurring, it could also lead to some form of clotting cascades going on, leading to depletion of the clotting factors in the system. Then you have the liver disease. So like I did mention previously, liver disease, or the liver has a role to play when it comes to clotting factors production. Sepsis, infection. During infection, there's going to be some form of inflammation, and that could also lead to some form of clotting cascades or event happening, which can also lead to DIC. Then we have postpartum hemorrhage and blood loss. So in postpartum hemorrhage, you understand that the patient has probably had a cut during labor and the patient is bleeding. During the bleeding stage, you need the platelets, you need the clotting factors to come in to help stop the bleeding that is ongoing. In the event that this clotting factors and the platelets moving in to stop, it could be at a faster rate where you could have a depletion of the clotting factors and the platelets. And at long last, the patient will rather have issues with prolonged bleeding, or they will have what we call abnormal coagulation happening. And that will lead the patient into having disseminated intravascular coagulation. These are the predisposing factors. Generally, when it comes to pregnancy-related issues, these are the things you can associate with it. If you have a question you want to add on the DIC, you can bring it. So when it comes to the assessment, it has to do with generalized body bleed. You have a question on Madame Sylvia, the HELP syndrome. You have a question on it? Please, I explain what a HELP syndrome is. So, okay. Someone is saying, what is a HELP syndrome? I talked about the HELP syndrome, but I said the HELP syndrome, it's an acronym. The HELP is an acronym. H is hemolysis. Hemolysis is breakdown of red blood cells. Okay, premature breakdown of red blood cells. Red blood cells, I think I made mention of it when I was talking about glucose challenge test during glycated. I said that they last for about 90 to 120 days for a normal person. We don't have any issue. However, you could have a situation where the person red blood cells breaks down before the 90 to the 120 days. And so that is what hemolysis is about. So breakdown of red blood cells. Then the E is elevated liver enzyme. So the EL is elevated liver enzyme or liver enzymes. Then you have LP, low platelets. Okay, low platelets. So that is what the HELP syndrome represents. Okay. And all those factors or all those things I said can lead the person to go into DIC or can bleed severely. So the assessment findings are all tuned towards generalized bleeding occurring in the system. So you have uncontrolled bleeding. The person will tend to have bleeding under the skin. And so when it comes to bleeding under the skin, you can have various assessments. You can have bruising, you can have purpura, you can have petechia, you can have ecchymosis. And so all these things, defines or tells you that someone is probably bleeding. You see this form of bleeding under the skin, visibly under the skin, some form of skin discoloration. And that will tell you that the fellow is bleeding. Then you have occult blood. So occult blood is when the person passed stool and you see some trace of blood in the stool. So that is what occult blood is. And so at another circumstance, you don't expect to see someone passing stool with trace of blood inside. And so if you see the trace of blood in the stool, that should prompt you that the fellow is probably bleeding internally, internal bleeding, and you should do your further assessment on the person. You can have hematuria, hematemesis, vaginal bleeding, then signs of shock. At least if of course, if the person is bleeding, you expect shock to occur. Vital signs, heart rate going up, BP coming down. Then you have respiratory rate going up as well. Then the clotting factors are going to be decreased. Fibrinogen platelets will go down and hematocrit level will also reduce. Then we have what we call, prothrombin time, and then thromboplastic PT, and then APTT. This thing tells you how one is at risk of bleeding. And so if you have these values or these lab values being elevated, it means that the person is at risk of bleeding. So you have increased prothrombin time. In terms of the lab, you should monitor increased prothrombin time, increase thromboplastin time. If these values are elevated, that tells you that the fellow is at risk of bleeding. Then we have clotting factors or clotting time. Sorry, if clotting time increases, and we know that with clotting time, you need to, look at how long it takes for the person blood to clot. If that one too, the clotting time is also high, it makes that person is also at risk of bleeding. Then we could also have febrile degradation, which is also a clotting factor. So these are some of the things you could see with someone with DIC. The intervention for DIC, of course, this is bleeding. So like I said, the causative of the underlying factor, what is causing it, you need to target it and then you treat it. And so if it is about, let's say, a liver issue, probably the target would have to be the liver. If it is about the person is having postpartum hemorrhage, you have to target the postpartum hemorrhage and manage it. And so you have to look out for the underlying cause, and then you remove the underlying cause. You monitor the cause of shock. You monitor for signs of shock, and then you treat when there is shock. So in treating shock, we have oxygen, we have blood, we have IV fluids. Okay. Then we have heparin. So whenever I get it, people ask me, why do we give heparin when the fellow is bleeding? And we know that heparin is a blood thinner. Okay. And so the reason why you give the heparin, remember that the underlying cause of DIC, or what happens in DIC, is that we're saying that there is excessive clot formation. Okay, excessive clot formation. And that excessive clot formation is what, at the end of the day, will lead the person into bleeding. And so you have to target the clot that is forming. You give heparin to stop further clots from happening or further clots from forming. Okay, so heparin is useful in managing DIC to prevent further clots from forming. You monitor the complications associated with the fluids you are giving, and then blood, as well as the heparin you are giving. So you have to monitor the what is it? You have to monitor PT. Is it PT or APTT? Which of them do we use for heparin? Heparin is 1, 2, 6, 7, 7. So 7, we go in for APTT. So you get 10. That is how you can easily use to remember. Heparin has 7 letters. So you look out for the one you add to it to make 10, which is APTT 3. APTT has 3 letters. So you add 3 to the APTT, which has 3 to the 7, and you get 10. Warfarin has 8. Okay, 8 letters to make warfarin. And so you have to get 2 to add to it to get 10, which is Sandra. That you want something. Hello, Madam Sandra.
I'm just asking, what calculations are you making?
Don't get confused. Sorry for that. I believe you are new to it, okay? You will learn about it, okay? Sorry if you don't understand. We are looking at what I'm saying is I was talking about heparin, okay? And then I was saying that when you give heparin, you have to monitor the complication for heparin. And in doing so, you have to monitor this level. You see, we have PT, prothrombin time, and we have partial thromboplastin time. Okay. PT or prothrombin time is used to monitor the effect of warfarin, which is also a blood thinner. Okay. It is used to monitor warfarin level or the effect of warfarin. And so if you are giving warfarin, you want me to go into this. If you are giving warfarin and then you see I don't want to go into the numbers now, probably if not studied, but just generally, if you are giving warfarin and you notice that the prothrombin time or the PT level is high, okay, it's elevated, it means that the person is at risk of bleeding. So you have to stop the medication you are giving, or it means that the medication has been given in excess. And so you have to stop the medication. And the same thing, if you are giving heparin and then heparin, you want to monitor the effect of warfarin, you use the partial thromboplastin time, and that is shortened as APTT, yes. APTT, you can also term it as APTT. So you can also, so the partial thromboplastin time is the same as APTT. You have to use this one to monitor the effect of heparin. If it is high, if it is elevated, if this lab is elevated, it tells you that the person might have taken excess of the heparin. And so you have to stop the heparin or reduce you have to taper the dose down based on what the instruction will be from the healthcare provider. And what I was saying was that sometimes if you want to remember the NCLEX, you have to find a way to remember things. You take the abbreviation, the PT. PT has 2 letters. Okay. And we are looking at warfarin, heparin. Warfarin has 8 letters. And so if you want to know what you use to monitor warfarin, look at what you add to the 8 letters to get 10 letters. And so you can take the PT, which is 2, you add it to the 8 of the warfarin, you get 10. So you know that warfarin will go for PT. And then what I'm talking here, which is the heparin, has 7 letters. And then the PTT or APTT has 3 letters. Warfarin has 7. You add the 3 to the 7, you get 10. And you know that you are going to use PTT or APTT to monitor what we call heparin. That is the calculation I was doing. All right. Sorry if you don't understand it, but I believe you get it further when you read more. Okay.
Thank you.
All right. Thank you too. You have to also look at, yes, madam.
So PT is for, is that right?
PT is for warfarin.
Then heparin is
APTT. Yes.
PTT, yes.
Yes.
Okay, thank you very much.
All right, so let's go. That is how I used to remember. Whenever I get the questions on it, then I'll put my pens together and then because that was the simplest way I used to remember those things. All right, so that is on how to. So you have to look at for urine output. Very, very important. You monitor the urine output because the kidneys will need blood supply. And so if the kidneys are also not getting adequate blood supply, you know that there could be acute renal failure or there could be renal failure. So you have to monitor the urine output and ensure that the client is having a urine output of at least 30 ml per hour. Okay. So that is on the urine outputs. Let's talk about ectopic pregnancy. If you have a question on DIC, you can bring it on board before I go into ectopic. Okay. Let's go into ectopic and then we'll look at ectopic. So in ectopic, we are looking at, it's one of the common areas you meet whilst you are reading. And whenever you come across ectopic, look at things that will tell you that someone is asking the levels of PT we should hold. Okay, I'll drop. We are not going into that today, okay? But I'll drop. I think you might used to have that, charts on the two. I'll look for it and drop it on the page so that we can all have access to it, okay? So that we can continue with what we have for today. All right. I think for those who have the cardio, okay, those who have watched my class on cardio, it's on our YouTube page. The last class, I think last but one class talks about those things. I did an extensive review of the two. And so you can go to our website, you have all the YouTube channel, you look out for the cardio. I think the last but one class talked about PT and then APTT and a heparin warfarin and all those things. I did extensive on it. All right. So let's go into ectopic. In ectopic, we are looking at where the implantation of the fetus will be located. And as we all know that after fertilization, the fertilized ovum or the egg would have to move its suitable place for implantation and then development of various organs and then body parts. However, there are instances that after fertilization, instead of the fertilized ovum or egg moving to the preferred location or the appropriate place, which is the uterus or the womb, it will either remain in the fallopian tubes or it will move into somewhere in the abdomen to go and stay there, thinking of getting the adequate nutrients for growth and development. However, because that is not the appropriate position or the appropriate place for implantation to take place, the fetus will not develop as expected. And as a result, the woman will develop other complications or other. A lot of people have a mute and getting a feedback here. All right, it's muted there as well. So because the implantation is taking place at a wrong location, you have the woman experiencing a whole lot of issues. And again, the fetus is not also going to get the needed nutrients. And so the growth and development is also going to be affected. So we'll go a bit more into it and we looked at what we need to do for a client and what we should look out for when we are reading our questions with ectopic pregnancy. When it comes to ectopic, one of the things they like doing is, they give you things that will tell you that the person has probably had a rupture. Okay. And so we looked at what indicates or what comes together to form a ruptured ectopic. That is, and ruptured ectopic, where you are prioritizing and you have a ruptured ectopic client, you need to prioritize that person first before you look out for the other people, or you look out for the other client you have been given, even though you need to look at all the 4 options before you prioritize, and you use all the prioritization techniques or skills you've developed. But when it comes to ectopic and ruptured ectopic, it's mostly of high priority. I've talked about the most common location for implantation is in the fallopian tube with ectopic. That is the ampulla of the fallopian tube. It doesn't move, it stays in there. And because that is the wrong location, you have the issues popping up there. On assessment, of course, the woman is pregnant or fertilization has taken place. So the woman will come to you with missed menstrual period because there's been fertilization taking place. The woman is not going to have menses again. It will stop, just like what happens in normal pregnancy. Then, because the location is not the right place, the woman will complain of abdominal pain. In the early stages, sometimes around 10, 11 weeks of gestation, these issues will start developing. So you have abdominal pain. The woman will also have vaginal spotting. Okay, vaginal spotting to bleeding. That is dark red or brown. So that is how the vaginal bleeding looks like, if there is any. Then when it ruptures, there's going to be increased pain. We talked about abdominal pain. However, when it ruptures, the woman is going to have increased pain that referred to the shoulder, and then you look out for the vital signs of shock. So when you are reading your questions in prioritization and you come across ruptured ectopic, how would you know that this is ruptured ectopic? They will tell you the clients came, complain of missed menstrual period with increased abdominal pain, a pain probably referring to the shoulder. And then in the question, you see the vitals. They will probably might give you the vitals if they want to go further. And it's also case study. You have all these things I'm talking about in the case study. Vitals will be there. Heart rate will go up. Respiratory rate will go up. Then there's also going to be hypotension. So when you look out for all these things in your question, then it should point to you that this person is having ectopic pregnancy, which might have ruptured because of the shoulder pain the client is talking about. All right. Your interventions are that you need to do your assessment, vital signs. You monitor for the bleeding, and then you monitor for signs of rupturing, which I've talked about, and then shock. Then we give methotrexate. And so methotrexate, it's contraindicated in normal pregnancy. When you are looking for medications that are contraindicated in pregnancy, that will be the last thing I'll talk about for this class. When you're looking for the medications that are contraindicated in pregnancy, you look out for methotrexate. Methotrexate, it antagonizes what we call folic acid. Okay. You know, folic acid is needed for normal growth and development of the fetus and to help prevent some form of congenital abnormalities like I've forgotten this, but it helps to come. It helps to prevent congenital abnormalities. Spinal bifida. Thank you. So it helps to prevent spinal bifida and general well-being of the fetus. Okay. So if you are given a medication that will prevent the absorption of folic acid, then that means that the growth of the pregnancy is also not going to continue. So methotrexate is generally contraindicated in pregnancy unless it is ectopic, where the healthcare provider will give it. So it is given in ectopic pregnancy to treat early ectopic pregnancy, to treat the condition without surgery. Now, if you need to go in for surgery, we know that salpingectomy is the actual term that will refer if they had to go and work on the fallopian tubes. However, before you do, I remember last time someone asked me, why not salpingectomy? And I'm saying laparotomy. I'm saying laparotomy because before you open up, you need to open up before you get to what we call the fallopian tubes to work on it. And generally, if let's say there's ruptured and then other associated organs are also affected, so they'll have to also go and work on it. So laparotomy will be done probably to remove the pregnancy in the tube, if that's necessary, and then repair of the tube. And then we know that this is surgery, probably there is rupture, you have to target infection. So antibiotics are also given. Then you have to also look out for the rhesus status of the woman. If the woman is known to be negative, RhoGAM would need to be given as well. I think I also made mention of it when even we're talking about it. The next thing we'll talk about is hydrotheliform mole. All right, if you have a question on that, you can, if you have something to add on that topic, or you have something to add up on that topic or something like that, you can bring it on board, okay? Or you can add it up.
Please,
Yeah.
please, can you come again with the metro thesis? I'm forgetting that.
Methotrexate, okay. All right.
Thank you.
All right. So I'm saying that methotrexate is generally contraindicated in pregnancy. You don't need to take this medication in pregnancy. Okay, so let me, can someone confirm for us the routes for administering methotrexate? Okay. Someone is asking for it. You can just, I think you can just get it on Google. You can just say for it, okay. Is IMA?
Yes, I am.
Okay, thank you. All right, someone has helped us with that. So it's IM. So I'm saying that methotrexate is generally contraindicated in pregnancy. You don't give methotrexate in pregnancy. You only give methotrexate when the client is having ectopic. And I said the duty of methotrexate is that it antagonizes what we call folic acid. And folic acid is needed in the body during pregnancy to help with growth and development of the fetus and to help prevent congenital abnormalities like neural tube defect or spinal bifida. Okay. Yes. And you give it in the early stage of the pregnancy so that the pregnancy doesn't continue. When the moment you picked up that it is ectopic in the early stages of the pregnancy, probably you don't need surgery. Okay. In the early stages, surgery might not be done. They give the methotrexate and then the growth will stop. Probably, by that stage, it's still blood. Okay. So everything will come out. But then if surgery is needed, surgery will be done as well, like I talked about in the surgery stage. We have hydrotheliform mole. And so hydrotheliform mole and then ectopic looks a bit similar. However, one key thing that in your question you can use to differentiate between ectopic and then hydrotheliform mole is that in ectopic pregnancy, you can pick the fetal heart rate. Okay. The fetal heart rate can be detected, or you might be able to detect the fetal heart rate using your Doppler or using your electronic device. However, for a hydrotheliform mole, you will not be able to pick the fetal heart rate. And so that is one thing you should be able to use to differentiate between hydrotheliform mole and then that of ectopic pregnancy. Now, this is also an abnormal pregnancy where you have abnormal cells. You remember in ectopic, we said ectopic has to do with implantation. However, this one, after fertilization, you have cells, abnormal cells that could be carcinogenic or that could be cancerous in nature, attaching themselves to the fertilized egg. And when they get attached to the fertilized egg, they affect the growth and development. And because these are abnormal cells, which could be cancerous or non-cancerous in nature, the pregnancy might not be able to develop or continue as expected. And so the woman will also tend to have issues with the pregnancy, abdominal pain, coupled with other findings. One of the key things in hydrotheliform mole is also that they come with hyperemesis. So there's hyperemesis as well. They're going to have, some form of vaginal bleeding. We'll go through the assessment. So with hydrotheliform mole, like I said, it is abnormal cells, which the gestational trophoblastic disease, that is another term. So it's either you see hydrotheliform mole or you see, molar pregnancy. They also use molar pregnancy sometime. Okay, a form of gestational trophoblastic disease where you have trophoblasts, which are peripheral cells, abnormal ones, attaching itself to the fertilized ovum in the uterine wall. So this time around, you have the fertilized egg being implanted in the uterus, the right place. However, you are having abnormal cells that have attached themselves to the egg. And so these affect the development of the egg. You can have the mole might manifest on ultrasound. You might see some form of edematous grape-like clusters on ultrasound. So if our ultrasound is performed and they want to, know if it is, a molar pregnancy, that is what they will be looking out for. The characteristics they will be looking out for on it. It could be non-malignant or it could be, carcinogenic in nature as well. So you have to, to tell you that one of the management is that, or interventions is that you have to take a tissue to look at whether it was carcinogenic in nature or it was not carcinogenic, or whether it was malignant or it wasn't malignant. So you have to look out for that as well in the management. One of the main things I would want us to look out for in the management is, in your questions, you will see the time duration that the woman can get pregnant. Or in your options, they will ask you, after molar pregnancy, when can the woman get pregnant again? Look out for this. It's in my intervention. I'll make mention of it. So like I said, in your assessment, you have to look out for whether the fetal heart rate, you can detect it. I've already stated that in molar pregnancy, the fetal heart rate is mostly non-detectable. But in ectopic, you detect it. You're going to have hyperemesis as well too. Okay, so the clients will complain of excessive nausea, vomiting during the early stages of the pregnancy. You're going to have vaginal bleeding that may occur by the 4th week and not until the 2nd trimester. Then the bleeding will be bright red or dark brown in color and maybe slight, profuse, or intermittent. So they bleed. Vaginal bleeding is also there. Then signs of preeclampsia. We'll go through preeclampsia if you understand where preeclampsia starts from. Indeed, in fact, you can only diagnose preeclampsia after 20th week of gestation. However, if you have a client who is having a progressive increase in their blood pressure in the initial stages of pregnancy, it should click in your mind that it is probably maybe a molar pregnancy that is causing it. So you have to look out for what we call the the blood pressure, and you monitor the blood pressure as well. So if the blood pressure, you notice a progressive increase in the blood pressure, okay, in the early stages of what we call pregnancy, that could be what we call hydrotheliform or a molar pregnancy. So signs of preeclampsia: progressive blood pressure elevation before 20th week of gestation. Note that you can only diagnose preeclampsia after 20th week of gestation. Okay. Then the fundal height will also be more than the expected for that very gestational age. Remember, we have gone through the fundal height, where to locate the fundal height, at what gestational week you should see the fundal height, or where you should locate the fundal height at what gestation. if you notice that the fundal height, let's say someone comes to you and they say that, or you are reading your question, the fellow is at, let's say, 12 week of gestation, and the fundal height is somewhere around the umbilicus. That is not normal. And so that could also be that it is a molar pregnancy. Then there is an increase in what we call HCG level, human chorionic gonadotropin level. And in fact, you have to monitor HCG for about 1 year if someone has a molar pregnancy and the pregnancy is terminated. You have to monitor the HCG level for 1 year and make sure that within that 1 year, the level has dropped back to its normal stage or its normal level before the fellow will be allowed to have pregnancy or be allowed to get pregnant again. So in the management, HCG levels are monitored regularly for 1 year. So in molar or hydroxyliform, molar pregnancy or hydroxyliform, one of the labs you have to look out for is the HCG. Is the HCG more than 100,000? If it is there, then it means that, there is hydroxyliform. Then you also have a characteristic storm pattern on ultrasound when an ultrasound. So all these things could be described in your questions or in your case studies, and then you might be able to know that it is molar pregnancy you are reading on. The interventions are that you need to, of course, treat the underlying, or you have to evacuate. You have to do uterine evacuation. You have to remove the pregnancy that is there or the fetus. You have to remove everything. So you prepare the client for uterine evacuation. Before that, you have to do all your, yes, Madam Sandra.
What's the meaning of the snowstorm?
That is the appearance of the fetus on ultrasound.
Okay, thank you.
Yes, that is the appearance. So you have to do the evacuation, or the evacuation will have to be done to take off. Before evacuation, of course, you need to give oxytocin to stimulate contractions and all that. You monitor for postpartum hemorrhage infection. Like I said, tissue would have to be sent to lab to look out for whether, it is cancerous in nature or it is not cancerous. Then you have to also monitor the HCG level for 1 year. So HCG levels are monitored every 1 to 2 weeks until normal pregnancy levels are attained. Levels are checked 1 to 2 months for 1 to 2 months for 1 year. You have to instruct the client and a partner that they will need to use birth control measures so that pregnancy can be prevented for that 1 year duration. So that is on hydroxyliform or molar pregnancy, and the interventions, assessment, findings you need to also know with regards to our studies. A question you have, you can bring it up.
You can see the 1 to 2 months or something. I didn't get it correct. The 1 to 2 weeks or 2 months.
Okay, Mr. James Star, can you come? You say you didn't understand. You didn't get.
I didn't understand the 1 to 2 months thing that you were talking about.
1 to 2 months. Okay, so all that it means is that if the woman is having, or there is a molar pregnancy, evacuation has been done, the person is going home. We said that HCG level is going to go high in molar pregnancy above 100,000. And before the woman will be allowed to get pregnant again, HCG level must return back to the normal range. Okay, it has to be less than 100,000. And so in doing that, you have to do the monitoring every 1 to 2 weeks. Sorry, every 1 month to 2 months, depending on what the healthcare provider wants. The healthcare provider can say that come to the hospital for checkup every 2 months so that we monitor your HCG level. It can say that come every 1 month so that we monitor your HCG level, okay, for 1 year. But before that, you have to, sometimes the healthcare provider also, maybe in the first few weeks, you do, kindly mute out for us. In the first few weeks, the monitoring can be one to 2 weeks. Then he will continue, let's say every 2 months, let's say, 1 month. That is dependent on what they say. Mr. James Star.
Yeah, thank you very much. I do understand.
Yes, Tina, your hand was up.
Hello.
Yes, Tina. Yeah, kindly go ahead, Tina.
Within that 1 year, I'm asking that within that 1 year, if the HCG levels are okay, can the woman get pregnant? Or even if they are okay,
You
she
have to
has to
still
still wait
monitor
till
it for
after
1 year.
1 year before getting pregnant,
Yes. You have to
before she
still
can get
continue.
pregnant.
You have to still continue to monitor until 1 year.
Okay.
So
Thank you.
the monitoring should continue until 1 year, so that you now ascertain that throughout the monitoring, from the time it started dropping into the normal range, it had stayed within the normal duration, or sorry, that stayed within the normal range for that 1 year. Before, after 1 year, the woman can be allowed to get pregnant again. All right. So let's do, hyperemesis very briefly. It's one of the things, at least you should have a fair knowledge on it. It's not quite anything difficult. We all know hyperemesis where there is excessive nausea, vomiting. However, the stage at which the nausea, vomiting is occurring is the interest. We know that nausea, vomiting are expected in pregnancy, and in the first trimester, we expect nausea, vomiting to happen. However, if you have the nausea, vomiting extending beyond the first trimester into the third trimester, if you have the nausea, vomiting extending beyond the first trimester into the second and third, that is abnormal, okay? And this person will come with a severe nausea, vomiting. The interest here is that because of the nausea, vomiting, the person is going to lose fluid, okay? Electrolyte imbalances will also be a concern here. And then acid-base imbalance, okay? And then we know that the acid-base imbalance you monitor here, because the fellow is bringing out more acid. If you are vomiting, you are bringing acid from your stomach. And so it makes your system to become, high in base. And so you have metabolic alkalosis, okay? And so when you are doing for those of you who've not learned about ABGs, don't worry a lot. I'm sure a time will come, you learn it, so you get to understand the aspect of it. But you can just pick it out from here. If someone is vomiting, the person brings out more acid. And if you bring out more acid, your system will tend to have more base or alkaline. And so you will have metabolic alkalosis. All right. Then they also tends to lose more of potassium and other electrolyte as well because of the vomiting they will be having. So you have to monitor the electrolyte. And then if you notice any issue with any of the electrolytes, you have to manage it as well. The assessment findings for them is that nausea, vomiting, very key. Persistent vomiting, weight loss. If you vomit a lot, you know that if you want to equate weight and then fluid, 1 liter of fluid is equated to 1 kilogram of either body gain, body weight. So if you are giving your IV fluids and you want to monitor the response, can monitor the weight. So if you monitor the weight, you look at, is there any increase after giving your IV fluids? you have to also know that this person, and then it also affects what we call carbohydrate metabolism. The fellow might not even eat out at all. So weight loss is also there. Then signs of dehydration. They will come with fluid and then electrolyte imbalances, like I was talking about. So dehydration, electrolyte potassium is there. Acid base, look out for metabolic acidosis. So metabolic alkalosis as well. The interventions are, before you give your medication, at least you should try something. Okay. So you have to initiate measures to prevent the nausea and vomiting before you come in with your medication. So if unsuccessful with your management and the client is still losing weight fluid, then you might consider parenteral nutrition. So parenteral nutrition is where the client receives should I say diet through the veins. An example of that is TPN. And so for people with severe hyperemesis who are probably losing weight, not responding to other measures, you have to go in for parenteral nutrition if that is necessary. You monitor the vital signs, urine and output, weights, and then you monitor the calorie count as well to see how the client is responding to the diet you are giving. You have to also look out for your labs, okay? The various electrolytes, sodium, potassium. You have to look out for your acidosis, your alkalosis, to look out for, are they normal? And then this client, in the extreme stages, because the nausea and vomiting would affect their food intake, the system would now depend on stored fats, okay? They will now break down what we call stored fats in order to get energy or for energy. And during that process, there's going to be the release of ketones. So you have to also look out for ketones in the urine as well for these people. You have to also monitor the fetal heart rates to look out for how the fetus is doing. Has the problem affected the fetus? Of course, it's going to affect the fetus because the fetus also depends on the mother for everything. So you have to monitor the fetus to know the status of the fetus. Then you have to also encourage intake of food in small portion, okay? And you know that when it comes to food intake, we say that small frequent meal, because when the client takes in more food at the same time or a larger quantity of food at the same time, it causes the abdomen to become full. And when the abdomen becomes full, it can stimulate what we call nausea and vomiting. So you have to take in small frequent meal or small portion, okay? And it has to be low in fat, easily digestible carbohydrate, such as cereals, rice, and pasta. Those are the things clients should be encouraged to take. And when they are taking after eating, you need to make sure that, how to combine food and drink. So we say that you take the drink in between meal. So in between meal is that when you take in the food, wait for some time before you take in the food. Sorry, before you take in the fluid, just to prevent the abdomen or the stomach from becoming full, which can stimulate the nausea and vomiting or trigger it. You have to encourage the client to also sit up after taking meal, okay, as well, to also help prevent the nausea and vomiting triggering. So that is on hyperemesis gravidarum. I remember when I was doing the initial part, I think I made mention that one thing you will also do when a client comes with nausea and vomiting is that they shouldn't brush their teeth first thing in the morning. Okay. So brushing the teeth should also be after taking in dry carbohydrate. Okay. So he says that before the client wakes up from bed, you have to give them a dry carbohydrate, okay, or a dry crackers, so that they will take that one before they arise from bed. And then they have to wait for some time before they brush their teeth as well. Because if they brush their teeth first thing in the morning or first thing waking up, it stimulates what we call triggers the nausea and vomiting. That is that on hyperemesis and the other things I also talked about. If you have a question or you have an input, you can bring it up. But before we go through some few selected questions I was able to put together for this. All right. The nurse is providing education to a client diagnosed with a molar pregnancy. Which statement by the nurse requires intervention? 1. A uterine evacuation procedure is the typical treatment for removing the abnormal tissue. I can provide you with resources for coping with the perinatal loss if needed. You may start trying to conceive again as soon as you and your partner feel ready. You will need resource immunoglobulin following a molar pregnancy because you have an rhesus negative blood cell. Okay. Hey, who's talking for us to go? A lot of people prefer to chat. Talk small, okay? Just talk. I know we all know the answer because I just finished doing this. So tell me the answer.
3.
3. Okay. 3 is
3.
you may start
3.
trying to conceive again. Okay. As soon as you and your partner feel ready.
Because
Okay.
you said the person have to wait for us to continue checking for 1 year
Okay.
before she can conceive again to see whether it's within the normal levels before she can conceive again.
Okay.
I'll go for 3.
All right. So that is there. All right. Yes, Kabir.
Hello.
Yeah, Mr. Kabir, go ahead.
Please, I want to make another contribution, something that is
Okay.
similar
Go
to
ahead.
this, about raising the client for or whatever. I think similarly, if someone to a pregnant woman, pregnancy spouse, and then maybe they take productions for conception, and then they do evacuation of uterus. I think that one usually they allow the woman to rest the uterus for 3 months before going for another pregnancy.
Okay, so I struggle to
Is
get
that the
it.
case? Yeah.
But if I get you well, you say your contribution is that
I'm
if
saying that hello. I'm saying that this one, the one that said if you have a molar pregnancy, that the woman is not supposed to get another pregnancy immediately after the evacuation. And then I'm also making a point. Similarly, in the case of retained products of consumption, maybe normally pregnancy has aborted spontaneously, but then also room means of yeah, concession. That's
Yeah.
so that similarly they allow them to rest the uterus for
Rest
about
for 3 months
months to heal
before. Yeah.
before she can go in for another pregnancy.
Oh, okay. Okay.
Uh,
Okay. The points well made and understood. I hope we got what he was telling us, or his contribution. He was adding up to, allowing the woman to rest for some time, about 3 months, if there is abortion or miscarriage and there is any form of retained product for normal pregnancy after the evacuation of the uterus. The general instruction will be that the woman should rest, or the uterus should be rested for at least 3 months before the woman will be instructed to try to get pregnant again. I have a question on my screen. The nurse is caring for a client at 15 weeks gestation who has hyperemesis gravidarum. Which of the following findings will be consistent with the condition? A heart rate less than 60 beats per minute, moderate to high urine ketones, increased serum potassium level, blood pressure greater than 140/90. Okay.
Two. The answer is two.
The answer is 2.
Yes.
Someone is saying the answer is 2. Okay. She says that there's going to be ketones in the urine. Okay. Okay. The nurse is planning care for a newly admitted client with hyperemesis gravidarum. Which are the following interventions should the nurse include in the client's plan of care? Administer IV antiemetics, document intake and outputs, administer IV max sulfate, obtain a urine specimen to check for ketones, encourage the consumption of foods that are high in fats.
One, 2, and 4.
1, 2, and 4. 1 is antiemetics, 2 is document, 4 is urine sample for ketones. Okay, we will see. Yes, Madam Mary.
I think it's the same thing. We give antiemetic because the client is vomiting to prevent the vomiting. They have to document and do intake and out because the client is dehydrated. Then we have to monitor the ketone, do urine distich to monitor ketones. They said the client should take low fat diets in small quantities in order for easy absorption and to prevent the nausea and vomiting. So the number 5 is out. Magnesium sulfate is for eclampsia. This client is not having eclampsia, so I don't think we'll be giving such kind of tip. Thank you.
All right, thank you, Madam Mary. Thank you for your inputs. Okay. Ah. The nurse in the maternity unit is receiving the client's records. Which clients would the nurse identify as being at the most risk for developing DIC? One is a primary gravida with abruptio. 2, a primary gravida who delivered a 10-pound infant 3 hours ago. 3, a gravida 2 who has just been diagnosed with dead fetus syndrome. 4, a gravida 4 who delivered 8 hours ago and has lost 500 ml of blood. A primary gravida at 29 weeks of gestation who was recently diagnosed with gestational hypertension.
Okay, so please, I think I'll go for one. So one, because we mentioned that an abruptio placenta puts the person at risk. There's an abrupt detachment, and so there can be bleeding excessively. And then a primer who has delivered a 10-pound infant. That's just, I mean, a big baby. So there can be some tears and all that, which can increase bleeding and so on and so on. And then gravida 2 with a death, no, that one I'm choosing. And then with 4, you realize that losing 500 mils of blood for a normal SVD is normal. Yeah, and so that is out. But then 5, a primate at 29 weeks of gestation who has been diagnosed with gestational hypertension is also at risk. So 1, 2, and 5.
Okay. Yeah, Mary, Madam Mary.
Thank you very much. I think I will side with her. Abruptio is one of the danger signs in pregnancy where everybody will look up to think of bleeding, because the woman can bleed, the pregnant woman can bleed very seriously. Then with a big baby, to predispose the client to bleeding. Then the 500, the number 4. Number 4, normal SVD is bleeding equal to 500. It's a normal kind of bleeding that every woman will have to bleed after delivery. Then primary gravida at 29 weeks of gestation, who was recently diagnosed with gestational hypertension. We know that gestational hypertension will lead you to preeclampsia, which will further worsen and lead to at PPH. So the client is at risk of getting this thing. The number 3, I'm not. The dead fetus. I don't know whether the fetus is that inside or.
Say a gravida who has just been diagnosed with dead fetus syndrome.
I think the fetus died inside, eh? So if it's also at risk.
So your final answer is
1, 2, 3, and 5. I've taken 4 out.
Oh, okay.
Thank you very much.
Thank you. Thank you for your rationale, how you went about to arrive at your answer. So this is our final answer. One, 3, 5. Divide 10 by 2.2.
Please, let's look at the question again, sir.
So divide 10 by 2.2. What do you get? The question is this, sorry.
Hello, that's big baby, 4.5.
Okay.
Oh.
Okay, so it says delivered. Okay, delivered, but there's no added up. There's nothing added to tell you that the person is bleeding. It just says that the person is having a big baby, has delivered a big baby. 3 hours ago.
There's no risk factors here for number
There,
2.
there hasn't been anything added in the question that, or in the option that the woman is bleeding. So don't think that the big baby will make the woman bleed.
Can we please have a look at the answers again, Brother Amingo, please?
Okay,
Thank you.
this is the answers.
Thank you.
All right. So, Madam Mary, are you clear? Are you clear now?
I'm clear. Thank you.
Yeah. All right.
Please, can you show the reason for the answer again, please?
This one.
Yeah. Thank you.
Okay. A client who is being evaluated for suspected ectopic pregnancy reports sudden onsets, severe right lower abdominal pain, and dizziness. Which of the following additional assessment findings would the nurse anticipate if the client is experiencing a ruptured ectopic? Such that a blood pressure 82/64, crackles on auscultation, distended jugular veins, pulse of 120, shoulder pain.
I'll choose 1, 4, and 5.
Yes, hello.
1, 4, and 5.
1, 4, and 5. 1 is blood pressure. 4 is pulse of 120. 5 is shoulder pain. Okay. So they are taking the crackles on auscultation out and the distended jugular veins also out. Okay. All right, let's continue. All right, so that is the last thing on the questions. Okay, let's use the remaining time to do something else. Yeah, so we're done with those things. If you have any question, any inputs you want to make, kindly come up with it, so that we can clear ourselves our doubts, and then we continue with the next thing. All right, so let's go more into some other pregnancy related issues. And we're talking about preeclampsia and then eclampsia. Okay. So these two move together, eclampsia and preeclampsia, just like two things. However, one comes before the other. And so pre in everything we know is before. So before eclampsia, and eclampsia is seizures that occurs during pregnancy. And so if someone is having seizures in pregnancy, that is what we term it as eclampsia. And then before the eclampsia, the various things that goes on before the seizures comes in, that is what the pre also stands for. So preeclampsia is different from eclampsia. Eclampsia is, let's say, the main thing, the seizures, and then the periodic or the progressive rise in the client's blood pressure before the seizure sets in. It's what the preeclampsia stands for. Before you can, because preeclampsia comes first, before you can diagnose preeclampsia, that has to be after 20 weeks of gestation. That is why when we're doing molar pregnancy, and I was telling you that when you have the BP continuously increasing in before 20th week, you should look out for something else, but not preeclampsia. So this also typically, I mean, happens in a third trimester. You have, when it happens before 20th week, it is called an early onset. Okay, so we have the early onset and late onset. So if you have the progressive increase in the blood pressure happening before 32 weeks, you say early onset. After 32 weeks will be late onset. Okay. Another thing I also want us to also understand is that preeclampsia doesn't only happen, or preeclampsia and eclampsia doesn't only happen in the pregnancy or during pregnancy. It can even happen in the postpartum stage. So when you are reading your question, you might also come across it that a woman, maybe after delivery, goes home, complain of having persistent headache, checked her BP, the BP keeps on rising, complain of blurred vision and other things. It should tell you that probably the woman is having preeclampsia. So can also happen after delivery or in the postpartum stage. Yes, but Kabir.
Hello, hey, please, I have a concern with the first statement, like the definition or the description. So it usually occurs after 20 weeks of pregnancy. That is to say from 20 to like 40 or whatever. And then the second statement is saying that when it occurs before 32, that one is rather referred to early onset of pregnancy.
So what is the confusion?
The confusion is, I said the preeclampsia occurs after 20 weeks of.
So
the second statement is when it occurs before 32 weeks. Before 32 weeks of pregnancy, it's called early onset, right?
Yes. So let me take that again, okay, to clarify that. Yes. So preeclampsia is diagnosed after 20 weeks. However, between 20, let me put it this way, between 20 and 32 weeks, if the client, you notice that there is, you pick preeclampsia between that stage, between 20 and 32, it is early onset, or you term it as early onset preeclampsia. But if it is after 32 weeks, that will be late onset. So that this is telling us that preeclampsia can occur early and it can also occur later.
Okay.
But the week of gestation or the time at which you can diagnose it is after 32, after 20 weeks. That is when, if the BP keeps rising, that is when you can diagnose one as having preeclampsia. But the 32 is giving you like a classification of the preeclampsia, that we have early and we have late onset. All right. So I was saying that it can also occur in the postpartum stage. So it's not only about in pregnancy, after delivery, clients can still exhibit some of these things. Then when the blood pressure keeps increasing, and then you have the woman fitting, or the woman going into eclampsia, or the woman having seizures. That is when we say eclampsia. So seizures that occurs in pregnancy, which is linked with increasing blood pressure or progressive increase in blood pressure, we term it as eclampsia. We have the assessment. Should I talk about the predisposing factors? This thing I should have brought the predisposing before the assessment. So the predisposing is that the predisposing factors are that if the woman is a known hypertensive and then has gotten pregnant, okay, it put the person at risk of what we call preeclampsia and then eclampsia or gestational hypertension. Or there is the client has a history of placenta abruptio. It also a risk factor. Then if it is primary gravida or the person that is the first time the person is getting pregnant, okay, if that is the first pregnancy, most people, or during first pregnancy, most people tend to have what we call preeclampsia. Then family history, first degree. So when it comes to first degree, we are talking about direct relative, your mother, your direct siblings, not your third or second degree relative. Okay. But a close one, your mother, your sister, if you tend to have this thing in family, it could also be a risk for it. Then age. So that is why it is not good for women to get pregnant after, 40 weeks. That's why most women want to stay active between 18 and then 40 years. By then they want to finish everything because of the associated risk that comes with pregnancy if you tend to give birth later in life. So those who are older, 40 years or older, are also at risk of preeclampsia. Then we know when it comes to hypertension is generally common among Black Americans or Black people. Okay, so when you look at hypertension and you look at the various ethnicities, you see that Blacks are more affected. Then you also have to do with if the woman is also carrying multiple fetus. So those carrying more than one fetus are also at risk of increased blood pressure, which will lead to preeclampsia and eclampsia at last. Then a history of chronic hypertension, kidney diseases, or both of them could also put the client at risk of it. If someone BMI is high, we know that obesity itself is one of the risk factors for hypertension. And so if you are obese and then you get pregnant, the likelihood of getting preeclampsia is also high. Then metabolic syndrome. Now, if you have done endocrine, I believe you might have read about metabolic. If you have not done endocrine, when you get to endocrine, you do metabolic syndrome. And so in metabolic syndrome, we have 5 different conditions that puts one at risk of having cardiovascular disease, okay, or DM. The conditions or the conditions that comes together are: one, if you are already a known hypertension, taking medication for it, or a known DM, or you take medication to control your glucose level. 3, increased abdominal obesity. It's also one. Then we also have low levels of high density lipoprotein. And then the last one will be high levels of triglyceride or hypertriglyceridemia. These are the 5, the 5 conditions that put together for metabolic syndrome. However, it says that you don't need all these 5 things to be classified as having metabolic syndrome. At least you need 3 of the 5 conditions I made mention of for you to be termed as having metabolic syndrome. We are not doing metabolic syndrome, but I'm just giving you an overview of what metabolic syndrome is. So metabolic syndrome is also a risk because it puts you at risk of having cardiovascular conditions, which will ultimately affect your BP. Then we have, I think I've talked about carrying multiple pregnancy. So these are some of the things that put one at risk of having preeclampsia and later setting into eclampsia. Yeah, Tina.
Please, my question is
Mhm.
the thing for eclampsia. You're saying
Mhm.
that it cannot show postpartum. Does it have a specific day postpartum or not? And if that is the case, can you also say that if the person is having eclampsia postpartum, can eclampsia also occur postpartum? Or that one is only
Okay.
during the period of
Can eclampsia also occur in the postpartum stage? Is that
postpartum?
what you are asking?
Yes.
Oh, yes, yes, it can happen in the postpartum stage.
And let's
But-
say it happens after what period can you say that this is no longer preeclampsia or eclampsia in postpartum?
Oh, okay. So you are asking of at what stage can we see that postpartum, this is not preeclampsia. So you have to look out for, I mean, it's not within some few days in the postpartum, okay, that you have to monitor the blood pressure. If you monitor the blood pressure within the very few days, I think the very few days, I'm not quite sure of the weeks. That's why I'm not giving you the.
Within the 6 weeks, 6 weeks. Postnatal is 6 weeks. So after
Okay.
the 6 weeks, it's considered as chronic hypertension, meaning you were having
Correct.
hypertension
Okay.
before
Okay.
pregnancy.
Okay. Okay. I wasn't sure of the weeks. That's why I wasn't giving you the. So thank you. So it's 6 weeks.
Okay.
All right. So we are looking at
Okay.
a 6 weeks duration. Okay. All right. So if
Okay.
someone
Thank
goes
you.
into preeclampsia, what we are looking out for is hypertension. I mean, of course, that is the main thing. Then we're looking out for swelling of the face. Look at what the swelling is. We are not talking about generalized, I mean, edema. We are looking at swelling of the face and the hands. Okay. The reason why the feet are not there is that we know that some people could, I mean, in pregnancy, because of the pressure from the uterus, some women tend to have fluid or edema in the legs, okay, the lower extremities. So if someone is having edema in the lower extremities, you can't say that that is a sign of preeclampsia. But if the edema goes into the hands and that of the face, okay, then that should tell you that, I mean, something is quite really wrong. So you need to monitor the woman for preeclampsia. Then headache, okay. We know we are talking about hypertension, and when there is hypertension, there's going to be increase in intracranial pressure and all that. I mean, a lot go on, so there's going to be headache. I mean, then we also have sight issues. So the client will talk about changes in the eyesight. So if they have issues with vision, that would also prompt you that this client is experiencing. That is why I was telling you that in the postpartum stage, if the woman between postpartum, the first is if the client is experiencing blurred vision together with headache and then other things in here, then you should think about preeclampsia the client is experiencing. Then pain in the abdomen or shoulders, nausea, vomiting in the second half of the pregnancy could also be there. Then sudden weight gain could also be there, coupled with difficulty in breathing as well. So when it gets to difficulty in breathing, then you know that the situation is becoming worse. So you need to do something to help the woman. So these are some of the general assessment findings you can associate with this. Preeclampsia is one of the, if you are in the maternity ward, okay, all your attention is on preeclampsia, all your attention is on postpartum hemorrhage, okay, where I work, okay. I mean, the hospital I work, I mean, go to maternity and all they are saying is preeclampsia, and they are talking about postpartum hemorrhage and all that. Those are some of the critical things that if you are in maternity ward or unless when you are preparing yourself for NCLEX, at least for maternity, you should have an upper hand on them. So when it comes to the complications accompanied it, I think abruptio we cannot make understand that it could cause the the placenta to, separate prematurely. Could also lead to DIC. I made mention of that. Fetal growth restrictions. Because of the constant or the progressive increase in the pressure, the fetus might not be able to get the needed oxygen, nutrients, and other things for growth. Then, so this is rather, gestational hypertension. Whether you refer to it or as gestational hypertension or preeclampsia, it's all the same. Then ICP. I talked about the fact that pregnant, we know that when your BP keeps rising, at long last, it also affects the intracranial pressure. It can lead to increase or intracranial hemorrhage. And so we have to also monitor that. Then you could also have some form of, liver issues, hemolysis. The HELP syndrome would also be there. Then there could also be the amniotic fluid amount will also be affected. So oligohydramnios. Then you also have placenta insufficiency, where we're talking about the amount of blood supply through the placenta to the fetus. Then you could also have what we call preterm delivery, or the need for cesarean section as well. So depending on where it is, the gestational age that the woman is experiencing the issue would also determine the intervention you have to go in for. Let me see. Let's finish with the interventions and we drop it here. Okay. I know the time is up. Let me just finish up with the interventions very quickly in about 5 minutes. Then we drop it there. You have blood pressure control is there. You need to monitor the blood pressure. Please don't leave after the class. I have something to say. Okay. Kindly don't leave. You monitor the blood pressure closely. That is a key thing here. And then when a client is discharged and they are going home, especially the postpartum stage, they need to monitor their blood pressure. They have to weekly or bi-weekly healthcare visits may be necessary. Delivery may be recommended at 37 weeks of gestation or earlier based on whatever is happening to the fetus. Fetal activity, you need to monitor. We monitor the fetal count in terms of fetal movement, okay, to see as to whether the fetus is doing well. Fetal growth on a monitor, you have to monitor how the fetus is doing on ultrasound, all will be done. Then you encourage rest, okay, you don't want the woman to stress a lot. And so, encouraging rest, positioning left lateral, very, very important. And then you have to administer your blood pressure medications. And we know that when it comes to blood pressure medications and then maternity, very, very important, which blood pressure medications that you can give. We know that our calcium channel blockers are safe to be given. Nifedipine is safe to be given. Metadopa is safe to be given. Then if you want to go higher, maybe hydralazine and that. But then your ACE inhibitors are not allowed. Your ARBs are not allowed. Okay. So you have to look out for the blood pressure medications and which ones are allowed to be used in pregnancy. You have to provide adequate fluid. You monitor intake and output and all that. Okay. And then urine outputs, because the kidneys may be affected or there could be renal issues. So we have to look out for renal perfusion as well. Then we are looking at level of consciousness deteriorating, because we said that these people will tend to have, intracranial hemorrhage, which could lead to increased ICP. So you have to look out for cerebral perfusion and to see as to whether there is any form of cerebral hypoxia. So that will affect the level of consciousness of the individual. So you monitor that one, you monitor for seizures if the person is going into what we call preeclampsia. Then you have to look out for deep tendon reflexes. And so when our deep tendon reflexes, it talks about how we control, our reflexes, our hands. And when someone is in the eclamptic stage and they are in the seizure stage, they have hyperreflexia, or their reflexes goes up. And so myself, you who doesn't have any issue with seizures or who is not having seizures, we know that we are able to control our reflexes normally. And our reflexes are graded from 0 to 4. Normal reflex is 2. That is the ideal reflex. So as at here, if you are to grade me in terms of my reflexes, you grade me as having a reflex of 2. If someone is having seizure in a patient like an eclamptic patient, the person will have hyperreflexia, and hyperreflexia is either 3 or 4. Okay. Then we also talk about hyporeflexia. Hyporeflexia is when your reflexes is below 2. So either 0 or 1. 0 means that no body movement or no reflexes. Then 1 will be hyporeflexia. Your reflexes has reduced. And this is what will also guide you to understand the use of magnesium sulfate. That if you are giving magnesium sulfate to treat either eclampsia or preeclampsia, if it is seizures, that is the reason why you are giving your max sulfate. The max sulfate is to bring the reflexes down. And so if you are giving the max sulfate, you expect the reflexes to drop. If it is 4, to drop to either 3 or 2. However, if the reflexes still stays at 4, or the reflexes keeps increasing, then that tells you that you have to either increase the dose of your max sulfate, or if the reflexes is either 0 or 1, and they are asking you what you do if a client is on max sulfate, what you do is that you stop the max sulfate immediately if someone's reflexes either 1 or 0, because it means the person might have taken excess of the max sulfate. That is why their reflexes is either 1 or 0. So the ideal reflex is 2. So you have to monitor, deep tendon reflexes. You have to monitor for HELP syndrome. I've talked about HELP syndrome several times. Then you have to monitor the renal function. You do 24-hour urine collection for creatinine clearance and then protein, because preeclamptic people tend to have excess protein in their urine. So you have to monitor the protein levels as well. Then I've talked about max sulfate. We'll talk about max sulfate specifically, and then we'll look at the complications you monitor for. I think I even have it here. The toxicity, if there's max sulfate toxicity, you have flashing, sweating, hypotension, decreased deep tendon reflexes, decreased urine output, and then central nervous system depression. These are things that if someone is experiencing and they are taking max sulfate, it tells you that the person is experiencing overdose or toxicity of the medication. So you stop the medication, you give calcium gluconate as soon as possible. Madam Mary, your hand is up.
Please, thank you. I wanted to find out, is there a way that the client can have the seizures whilst the distance level is low?
What level?
Like the reflexes is
No.
absent, or
If your reflexes is low, no body movement though.
oh, okay. It just
Yes.
hit my head and I wanted to clarify.
Okay.
Thank you.
If your reflexes are low, no body movement, so there wouldn't be seizures. I hope you get. Okay, so this bring us to an end of today's class. Okay. So let me pause.